Welcome back to the deep dive. Today we are taking a really fascinating journey through the diagnostic roadmap for heart failure, or HF. This is one of those areas in medicine where the initial symptoms can seem, well, almost obvious, but the actual diagnosis is anything but simple. We've got a whole stack of sources here that map out the clinical investigation process, and here's the central challenge right at the top. When a patient comes in breathless with, say, fluid retention, HF is the prime suspect. But those signs, that swollen leg, that cough, they aren't specific enough. They're not sensitive enough. They can mimic so many other
Yeah,
things.
exactly. The symptoms, they might get the patient in the door, but they don't really give the clinician the final answer. What's really required is a very high index of suspicion,
Mm.
especially for you if you happen to fall into those high-risk categories.
And those would be,
Anyone who's a bit older, or someone with a history of underlying cardiovascular disease, or, people managing comorbidities like hypertension, diabetes, chronic kidney disease. So our mission today is really to pull back the curtain on this multifaceted approach. We're going to unpack how clinicians actually confirm the diagnosis, and then how they kind of aggressively hunt down the underlying cause, which is just essential for the right treatment, and finally how they establish the prognosis. How serious is this, and what does the future look like?
okay, let's start at the very beginning then, the initial assessment. Before any big, expensive test is ordered, it all comes down to a thorough history and a physical exam. What are the guides telling us they're looking for right off the bat?
Well, they're acting like detectives. They're hunting for the cause of the failure. So that means not just tracking those key comorbidities, uncontrolled high blood pressure, diabetes, things like that, but also digging into things that might be reversible.
Reversible, like what?
This is where they start asking about exposure to cardiotoxins.
Ah, so things like chemotherapy.
Exactly. Did you have certain chemo treatments years ago? Is there a history of chronic heavy alcohol use, illicit drug use? All of that is on the table. And family history is crucial here too. They're looking for patterns, sudden cardiac death in the family, or unexplained cardiomyopathies. That might suggest a genetic link.
So once that history is gathered, where do they go next?
Immediately to the standard lab package.
And what's in that?
It's the baseline blood work you'd expect, really. A comprehensive metabolic panel, a complete blood count, coagulation studies, and a urinalysis.
Yeah.
And these tests, they aren't for diagnosing HF itself. They're essential for two main things. First, to rule out non-cardiac issues, like a severe thyroid problem that could mimic HF.
And the second thing.
To measure the systemic impact that the heart failure is already having on the rest of the body.
Right, and this is where it gets really interesting, that body-wide connection. HF isn't just a heart problem, is it? It's a failure of the central plumbing system, and the sources really highlight how you track that.
Absolutely. The kidneys and the liver, they immediately start to register the stress.
Okay, so talk me through the kidneys first.
With the kidneys, you'll see elevated blood urea, nitrogen BUN, and creatinine. That's very common in moderate to severe HF. It happens because the failing heart leads to reduced renal blood flow. But, and this is critical, you also get increased renal venous pressure.
So the blood is backing up.
Exactly. The blood is backing up into the kidneys.
So the kidney is struggling because it's not getting enough flow forward, but at the same time, the backup pressure is too high. It's getting hit from both sides.
That's a perfect way to put it. Now, what about the liver? In chronic right-sided heart failure, that venous blood backs up into the whole system. This leads to something called congestive hepatomegaly. The liver literally swells because it's so congested with blood.
And that shows up on the labs.
It does. You'll see modest elevations in liver enzymes, transaminases, alkaline phosphatase, and bilirubin.
But that's tricky because those same enzymes usually point to a primary liver disease.
That's the nuance, you're right. A clinician has to be very careful not to confuse this with, say, a problem in the biliary tract. The liver looks sick, but the problem is the plumbing. It's backed up, not actually diseased itself.
But what if those numbers are really high?
Now if they see marked elevations, especially with lactic acid, that suggests something much, much more severe, a catastrophic low-output state. We're talking cardiogenic shock, where the whole system is collapsing.
It's incredible. Those simple lab markers tell you not just that the heart is struggling, but how badly the downstream organs are suffering. It's a full body status report. So if that's the general organ function, what about specific things in the blood that act as warning signs? Let's talk about electrolytes and anemia. These seem to carry a lot of prognostic weight.
Oh, they're critical.
Yeah.
Especially because the disease itself, and frankly, the treatments we use, often introduce new risks. Take sodium. low sodium, or hyponatremia. This isn't just some quirky side effect. It's from sodium restriction from diuretic use and also vasopressin-mediated water retention. The body is trying to cling to fluid.
And that's a bad sign.
It's a profound negative prognostic indicator. If a patient is hospitalized and their sodium is low, it predicts a significantly decreased long-term survival. That's why it gets so much attention.
Okay, and what about potassium? It sounds like a constant tightrope walk for the doctors.
It absolutely is.
Right.
You have hypokalemia, or low potassium, which is often caused by loop or thiazide diuretics. They just flush potassium right out. But on the flip side, you have hyperkalemia, high potassium, that's often from reduced kidney function, made worse by the very medications we need to use, like RAAS inhibitors.
Right, so the drugs we rely on to help the heart, those are the same ones that can mess with the body's ability to get rid of potassium.
Precisely. The drugs you use to save the heart can be the very ones that throw the patient into a dangerous rhythm. Both low and high potassium dramatically increase the risk of arrhythmias. The margin for error is tiny.
Okay, let's touch on anemia. We know it makes people feel worse, but does it actually help diagnose HHF?
Not really. It's rarely diagnostic on its own.
Yeah.
But when it's there, it absolutely makes underlying ischemic heart disease worse. You just have fewer oxygen carriers.
So it has to be corrected.
It has to be corrected. And just to add a fine point, in very rare cases, a severe uncorrected anemia can actually cause a high output heart failure. The heart is just working itself to death trying to compensate.
But the real surprise finding in the sources, the one that's getting more and more attention, has to do with iron, specifically.
Yes, iron deficiency. It's incredibly common in chronic HF, and here's the kicker, with or without actual anemia.
So you can have normal red blood cell counts, but still be iron deficient.
Exactly. And the key takeaway for you, for the listener, is the treatment. The research shows that IV iron repletion leads to measurable improvements.
What kind of improvements?
Better symptoms, increased exercise capacity, and a really significant reduction in subsequent hospitalizations for heart failure.
Wow. So treating a simple nutrient deficiency is now a standard therapy for cardiac symptoms. That really changes how you think about what a heart problem even is.
It really does. It's a systemic energy problem.
Let's shift gears from blood tests to the first look at the structure. The chest X-ray, or CXR, it's often seen as pretty basic, but it can give you some immediate, crucial clues.
It does. The CXR gives us rapid visual evidence of left heart failure. First, cardiomegaly, an enlarged heart. We measure that with the cardiothoracic ratio.
Anything over 0.5 is considered enlarged, right?
That's the general rule. But more importantly, it shows signs of pulmonary venous congestion. That's fluid backing up into the lungs. In an acute failure, you look for these classic signs like upper zone venous redistribution, where the blood flow gets shunted upwards. And you see a thickening of the interlobular septa.
And if it's really bad?
If it's severe, you see alveolar edema. That's that diffuse haziness you see settling in the lower parts of the lungs.
Okay, but here's the trap that the sources highlighted, the aha moment. The absence of all that fluid in a patient with chronic heart failure doesn't mean they're getting better.
Exactly. This is so important. A clinician could be falsely reassured by an X-ray that looks less congested than they expect. The body has adapted.
How does it adapt?
Over time, the body's lymphatic system gets much, much better at removing that excess fluid from the lungs. The body is compensating for the chronic weakness. So a clear CXR is helpful, but it never, ever overrides a strong clinical suspicion.
Okay, let's move to the electrical map. The electrocardiogram, the ECG. We know it doesn't diagnose HF, but it gives critical context. What are we really learning from it?
We're learning about the origin of the trouble. For instance, if we see signs of left ventricular hypertrophy, a thickened heart muscle, or left atrial enlargement, that points very strongly toward heart failure with preserved ejection fraction, HFpEF.
The stiff heart scenario.
The stiff heart, often from long-standing hypertension or aortic stenosis. On the other hand, if you see Q waves, that suggests ischemic heart disease, damage from prior heart attacks. But pay attention to the pseudo-infarct pattern. That's Q waves plus a reduced QRS voltage. That's a huge clue for something like amyloidosis, where abnormal proteins are stiffening the heart wall.
And what about the risk of sudden death? The ECG gives an immediate glimpse into arrhythmia risk, doesn't it?
It absolutely does. Atrial fibrillation is present in up to 40% of chronic HF patients. And frequent PVCs, premature ventricular complexes, or runs of ventricular tachycardia, those are major markers of increased risk.
And there's a specific treatment link there, isn't there?
Yes, and this is fascinating. The sources point out that very frequent PVCs can sometimes actually cause a cardiomyopathy that is completely reversible.
Reversible.
Completely. And it can be successfully treated with an ablation, a procedure to stop that abnormal electrical firing.
That's incredible. A reversible cause just hiding in the electrical tracing.
And finally, the ECG is critical for deciding who might benefit from cardiac resynchronization therapy, or CRT. That's a specialized pacemaker. The decision is based on the QRS width and whether there's a left bundle branch block.
So we've gathered labs, X-ray, the electrical map. Now we get to the cornerstone of diagnosis and management, echocardiography.
The echo is the workhorse. It's fast, it's accurate, and it gives you a precise look at ventricular size and function. It checks the heart valves, and it can spot immediate dangers like blood clots or fluid around the heart.
And this is where we get that number everyone talks about, the left ventricular ejection fraction, or LVEF.
Yes, the LVEF tells us how well the left ventricle is pumping. 50% or greater is generally considered normal systolic function. But the echo is a multi-tool. We use Doppler techniques to estimate cardiac output and measure pressures in the pulmonary artery. And, crucially, they detect diastolic filling abnormalities.
The heart's inability to relax properly.
Exactly. If the heart muscle is stiff, it can't relax and fill. The echo lets you watch that stiffness in real time, telling you this isn't just a pumping problem, it's a relaxation problem. That's essential for diagnosing HFpEF.
So when the echo is done, but the cause is still a bit murky, or you need a deeper look at the tissue itself, that's when we move to advanced imaging, like cardiac MRI.
Right. CMR has become unbelievably powerful. It's highly accurate and quantitative for measure of muscle mass, volumes, function. But unlike echo, it excels at tissue characterization.
Tissue characterization.
By using techniques like late gadolinium enhancement, the CMR can literally map out scar tissue, inflammation, or abnormal protein deposits right inside the heart muscle.
So it's not just showing us the shape anymore, it's showing us what the tissue is made of.
Precisely. That makes it crucial for pinning down specific causes of HF that you might miss otherwise. Things like myocarditis, amyloidosis, hemochromatosis, or just defining the exact extent of the scar from a heart attack.
What if a patient has a device and can't get an MRI?
Then cardiac CT can be useful, especially for ruling out pericardial disease. And at the highest end, you have cardiac PET, which is usually reserved for really complex cases like evaluating inflammation in conditions like sarcoidosis.
Right, before we get to invasive procedures, let's cover two last crucial tools: biomarkers and functional testing. We hear a lot about natriuretic peptides.
Right. The natriuretic peptides, BNP and NT-proBNP, are incredibly useful as adjunctive tools. They're stress hormones. The heart muscle releases them when the wall tension increases. They're very helpful in diagnosis, especially when a patient shows up with shortness of breath, with dyspnea.
To figure out if it's the heart or the lungs.
Exactly. It helps the clinician make that call quickly. They also help establish how severe the disease is and can even guide dosing for certain medications. But there are some important nuances here.
What are those caveats?
Well, levels are usually higher in the pumping failure type, HFrEF, compared to the stiff heart type, HFpEF. But they can be falsely low in obese patients.
Why is that?
Fat tissue tends to clear these peptides from the blood. And on the flip side, a whole host of non-cardiac factors can raise them. Advanced age, being female, kidney disease, atrial fibrillation, even a pulmonary embolism. So they're valuable, but you have to interpret them in the full clinical context.
And for objectively measuring function, getting past symptoms to hard data, we have cardiopulmonary exercise testing or CPIT.
CPIT isn't routine, but it is the ultimate objective tool for risk stratification. It's absolutely essential when patients are being evaluated for big interventions, like an LVAD or a heart transplant. The key parameters, peak VO2, which is peak oxygen consumption, and ventilatory efficiency, are independent predictors of survival.
So it tells you exactly how much reserve a patient has left.
That's it. It's the gold standard measurement. It can also help define the cause of dyspnea when the initial diagnosis is still uncertain.
Finally, we arrive at the invasive studies. When all the non-invasive tools aren't enough, or a patient is in crisis, you have to go inside.
Correct. In the ICU setting, for patients who are hemodynamically unstable, a pulmonary artery catheter might be needed. It's key to differentiating cardiogenic from non-cardiogenic pulmonary edema.
And for managing IV drugs in real time.
Exactly. You can precisely manage things like vasoactives and diuretics because you're measuring filling pressures and cardiac output second by second.
And in the cath lab.
Cardiac cath serves a couple of purposes. First, By measuring pressures in the right and left heart at the same time, it's the only definitive way to distinguish restrictive cardiomyopathy from constrictive pericarditis,
Two very different conditions that look similar on the outside.
but require completely different treatments. Second, coronary angiography is mandatory to rule out ischemic heart disease as a reversible cause. If there's a blocked artery, you have to fix it.
And the most specialized, least common test, the endomyocardial biopsy, taking a piece of the heart muscle itself.
That's reserved for very specific high-stakes situations. Indications would be detecting active myocarditis, definitively diagnosing something like amyloidosis, evaluating LV failure from chemotherapy, or screening for rejection in transplant patients. It's the test of last resort when you absolutely need a tissue answer.
Wow. This roadmap it's truly comprehensive. It starts with just a conversation and a suspicion, then moves through labs that show you the whole body is involved, through the electrical map and advanced imaging, and only then, if the mystery is still there, do you go invasive.
And synthesizing all of that is the real art of medicine here. The flow is logical. History, labs, ECG, echo. Then you determine the cause, and finally, you stratify the risk based on everything you've gathered. Every single step is aimed at answering those two central questions. What caused this, and what's the prognosis?